Before surgeons talk about diabetes, they should learn what is diabetes. Diabetes is a new era in the field of surgeons. We didn't learn well in our postgraduate books. So it's a new era, should start from the beginning. We should know what is diabetes, what is incidence, what is complications, what is the pathophysiology of diabetes. The incidence of diabetes, as the last reports, we have 387 million patients have diabetes worldwide, and this is equal 8.3 of adult people all over the world. We have 4.6 million deaths due to diabetes. Type of diabetes, we have what's called juvenile or type 1 diabetes, and this always often begins in childhood, and it is autoimmune disease. And this is complete destruction of beta cells, this is not our subject today to discuss. We have type 2 diabetes, which actually rates about 90 to 95% of our patients diseased with diabetes. Gestational diabetes and other specific types are very rare. The aim of discussing diabetes is not diabetes itself alone. We have to discuss what is the complications of diabetes, and because this is the most interesting to such a disease. Most of the complications of diabetes related to two pathophysiological elements, the macrovascular issue and the microvascular insult. The macrovascular is almost always associated and related with coexistent insulin resistance, dyslipidemia, hypertension, hypercoagulopathy, and endothelial dysfunction and subclinical inflammation, and this is mostly due to hyperglycemia or associated, and this is what we call metabolic syndrome. And it's always manifested as coronary heart disease, cerebrovascular disease and stroke, peripheral arterial disease. The macrovascular actually started even before the clinical manifestations of the disease. مرضى كتير بنشوفهم الأول بيشتكي من مشاكل السكر ويبقى discovered by the complication before the clinical manifestations. This is because neuropathy, retinopathy, and nephropathy is starting before the clinical manifestation of the disease. By the time of the clinical appearance, type 2 diabetes patients almost always have diabetic retinopathy in about 20 to 30% of patients, microalbuminuria about 10 to 20%, arterial hypertension about or more than 50%, dyslipidemia more than 66%, peripheral neuropathy more than 75%, endothelial dysfunction up to 100% of diabetic patients with type 2 diabetes has endothelial dysfunction. مش هتكلم كتير عن التريتمنت، احنا معانا دكتور محمد فهمي هو استاذنا في هذا المجال، لكن دايما always the treatment started by one drug therapy, metformin, become resistant, so we started 2 drug therapy. We started 3rd drug or initial basal insulin, then we start complex multi-dose insulin. Is that will prevent the complication? If we achieve, or if we're trying to achieve a normal glycemic control, can we control the complications associated with diabetes? The answer no. Almost always we cannot achieve a maintained normal glycemic state. We always have either increased glucose level or attacks of hypoglycemia. بيبقى عندنا العدوين اللي قصاد بعض. لو هندي ماسيف ثيرابي عشان تو اشيف ا نورموجلايسيميك ستيت بنقع في هايبوجلايسيميا. ولو خفنا من الهايبوجلايسيميا دايما بيبقى عندنا hyperglycemic state. وبالتالي most of diabetic patients most of times, especially in our undeveloped countries, there is no a good follow-up for about 70% of patients. Most of patients have uncontrolled diabetic state. What is our target in medical treatment or in diabetic surgery? Our target is to make the glycosylated hemoglobin below 7, LDL below 100, triglyceride below 150. Still, with the best ways of treatment, we have 68% of cardiovascular insult and stroke leading to death. We have one amputation each 30 seconds. The main cause for blindness and renal failure is diabetes. 10-year mortality is 51%. So, despite all efforts to control the disease medically, the microvascular complications such as retinopathy, nephropathy, neuropathy occur, and the cardiovascular complications are very famous and they are the leading cause of death. And so we still have a problem in spite we are treating diabetes medically. Consequently, the treatment of obesity, hypertension, hyperlipidemia, subclinical inflammation, and hypercoagulability is a major problem and must be coordinated with good glycemic control. ما ينفعش اعالج السكر لوحده والعيان عنده hypertension والعيان عنده hypercholesterolemia. طب لو كان عندنا حل للديابيتس وللhypercholesterolemia وللhypertension in one step. Outcome of non-surgical treatment. This is what we explained. And there is many papers discussing how difficult to achieve a normal glycemic state in diabetic patients. This is career. The net result that intensive glucose control did not succeed in preventing morbidity and mortality, but it duplicates the incidence of severe hypoglycemic attacks that needs hospital treatment. It does not improve the quality of life and is associated with what is called death in bed syndrome and increase of mortality by 3 to 4. Actually, this is a great problem. This is not easy. Diabetes is a major health problem. This paper was discussing the implication of hypoglycemic attacks on diabetic patients. As we see, patients, more than 49% of patients have minor episodes of hypoglycemia in 2 weeks. 29 has a major and severe attack of hypoglycemia in last year. Hypoglycemia both occurs in 17%. Daily fear of hypoglycemia. المريض عايش في رعب من الهايبوغلايسيميا أكثر من الهايبرغلايسيميا. 17%. 46 daily fear, Traffic accidents with injuries due to hypoglycemia while he is driving his car, 15%. Abandoned sport practice, 54. Abandoned car drive, 35. Go out of home, 25. Having sex, 23 abandoned having sex because he had attacks of hypoglycemia while having sex. Several, about 54%. So, conclusion of outcome of medical treatment without saying more details. I think this is enough to discuss how much the complications of diabetic patients while they achieve a good medical treatment. احنا ما بنقولش على الناس اللي هم ignoring their treatment، ده دول اللي بياخدوا علاج كويس للديابيتس. This is their quality of life. This is retinopathy, neuropathy, renal insufficiency. This is how much countries paying and how much the person pay for his disease on annual rate. First year, this is economic-wise, he pay about 1,288 euro per year for his disease. You see, at 6th year, he pays 3,845 euros and more. So, if we can classify our patients according to their weight, what is normal weight and what is obese? We all know that normal weight or acceptable range between 20 to 25, overweight 25 to 30, obese from 30 to 40, and morbid obese above 40. Let's know what can we imagine when we say body mass index 25. Body mass index 25, for example, person who has 160 centimeter and his weight 64. I think in our country this is a normal weight person. So if we have a surgery who can be done for what is we called overweight, or for example a person who has 160 centimeter length and weight about 64 and body mass index about 25, if we have a surgery for him to finish his problem, could we say no? This is the resolution of diabetes mellitus after bariatric surgery. This is in morbidly obese patients. The results we all know. It's amazing, this complete resolution. We can see that gastric bypass and piliopancreatic diversion has the highest rate because they are not only a restrictive procedure like band or sleeve gastrectomy, but they have a malabsorptive pattern which interfere with the intestinal kinetics. We can see surgical treatment of diabetes in normal body mass index 24 to 29 versus body mass index about from 30 to 34. This is actually clinical results of studies from many of professors all over the world, many published papers. We can say Debola, Kumar, Cohen, Ramos, Glenos, Lee, all of them done for comparing body mass index before, normal body mass index to obese patients. We can see before surgery body mass index, projector? It's okay. Body mass index before surgery, we can see doesn't work. we can see body mass index as the red arrows show 28, 27, 29, 31, 27, 31, 29 is blue 30. Can we look to the glycosylated hemoglobin in the last column? We can see glycosylated hemoglobin 5.7, 6, 6.3, 5.9. We can see all patients achieve a normal glycosylated hemoglobin after surgery. This is in body mass index blue 35. We can look to the effect of mini gastric bypass on the remission of diabetic states of patients. This mini gastric bypass complete remission is in 78% and control in 11%. لو جمعناهم على بعض, we have about 90% success rate and control of diabetic state after mini gastric bypass. Of course, mini gastric bypass and Roux-en-Y should be higher than the restrictive procedures like pen and sleeve gastrectomy, as we can see this is obviously in this strategy. In the last year, it was an honor to us to have Professor Garcia Caballero, the Spanish professor, who starting actually what is called the anti-diabetic surgery the mini gastric bypass and its effect on diabetic patients in normal body mass index. And he published his famous paper, Improvement of C-peptide 0 in body mass index between 24 to 34 diabetic patients after tailored one anastomosis gastric bypass, and he's calling it BAGWA. This is Professor Garcia here the last year. And then we have been in Malaga, in Spain, with Professor Garcia. Here you can see Professor Selick, Professor Taquino, and Professor Garcia, and my colleague, Dr. Ihab Abdelmajid, and me, and many of our colleagues. The main issue, we're discussing the effect of mini gastric bypass on patients with normal body mass index. The results was amazing. So, we speak about the outcome of non-surgical. Let's talk about the outcome of diabetic surgery by mini gastric bypass. We have complete stoppage of anti-diabetic treatment in most of cases. 85%. This is randomized. We have normal hemoglobin 1A in more than 70%. We have no hypoglycemic episodes in insulin-dependent patients who was insulin-dependent. We solve neuropathy completely. You know what is Glavand-Stocking hypothesia of diabetic patients? It's very irritating. It makes the patients not sleeping. We have stop retinopathy, nephropathy, cardiopathy, peripheral vascular disease, great improvement of general health and quality of life, more work capacity. All patients were satisfied and said, if we did not do this surgery, we will regret for it. So we can pass this. We are not in need actually to show the effect of bariatric surgery, because now it's known and we can say it's not bariatric surgery, effect of anti-diabetic surgery on diabetes, because it can be done in normal weight patients. This is the role of bypassed proximal intestine in the anti-diabetic effect of bariatric surgery. We can see these numerous studies, including meta-analysis of 22,000 patients, confirmed that 83 to 86 of patients with diabetes experience complete remission of their disease after gastric bypass. Normal blood glucose, normal hemoglobin, glycosylated hemoglobin, and stoppage of all their treatment. What mechanisms could mediate such a profound improvement in diabetes? ايه الحاجة اللي في الجراحة اللي عملت التأثير القوي ده؟ اللابتوب هيفصل شحن. We have what we call upper GIT theory, as discussed by Dr. Selig. This is what is called before foregut theory, and this is the exclusion of the duodenum and upper jejunum. Duodenum and upper jejunum, when excluded, actually we have malabsorption of about 70% of glucose, which was normally absorbed from the upper jejunum. But the more famous is the lower GIT theory, hindgut theory. Hindgut theory means we have a physical shortcut. احنا اختصرنا السكة على ingested nutrients. This leads to increase the L cell activity from ileum and colon. Actually leads to increased secretion of GLP-1. GLP-1 is known as a nutrient-stimulated glucose-lowering factor. Actually, it doubles to 10 times its ratio. And since we have the Roux-en-Y gastric bypass since about 40 years or more, the GLP-1 for such patients lasts increased by this ratio for more than 20 years. What is the effect of GLP-1? How could it improve the glucose hemostasis? Actually, it increases insulin secretion, increase insulin sensitivity through, as we discussed, not only hormonal way, but hormonal and neural effect.